Welcome to Optic Surgeon, the ophthalmology podcast.
Thrilled to be here.
Today, we're really diving into something important for you all. Madarosis. Eyelash loss.
That's right.
This is specifically aimed at our ophthalmic residents and final year MBBS students.
Yep.
We're going to structure it around, well, a real-world kind of presentation, the key anatomy you need to remember, a way to think about the differentials.
The framework.
Exactly. And then practical steps for workup, initial management, and, of course, a keyboard exam tip.
Essential. Let's jump in.
Okay, so let's start with a case. How might this actually present?
Right. Imagine a patient walks into your clinic and you notice, maybe subtly at first, maybe quite obviously, that they have thinning or loss of eyelashes.
Okay.
It could be both upper and lower lids. And they might say, oh, nothing else is bothering me. Or maybe they mention just some mild itching, a bit of redness right along the eyelid margins. But this finding, madarosis, even if it seems isolated, it can actually be the first clue, the tip of the iceberg, for a whole range of underlying conditions.
So it's a critical observation then?
Absolutely critical. Don't just brush it off.
Okay, so to understand why it happens, maybe we should quickly revisit the basics, the anatomy and physiology.
Good idea. So eyelashes, right, they're hairs. Like other hair follicles on the body, they have a cycle.
The anagen, catagen, telogen cycle.
Exactly. Growth, regression, rest. Anything that messes with that cycle or physically damages the follicle structure itself, well, that can lead to madarosis.
Makes sense.
And then think about the eyelid structure. You've got the tarsal plates, the dense connective tissue, giving the eyelid its shape.
Right, the backbone of the lid.
Precisely. And within those plates are the tarsal glands, or meibomian glands. Modified sebaceous glands, really important for the tear film's oily layer.
Okay, so the glands are key too.
Definitely. The health of that whole eyelid margin area where the lashes actually come out is crucial for normal growth and just keeping the lashes there.
And what about the muscles? Do they play a role?
Indirectly, yes. You have the orbicularis oculi that closes the eye, and the levator in the upper lid lifts it.
Right.
Inflammation affecting those areas or mechanical problems can sort of secondarily impact the lash follicles. It's all interconnected.
So basically, a problem anywhere along that line, follicle cycle, structure, glands, margin health, can show up as lash loss.
You got it. A disruption at any of those levels.
All right, so we see the lash loss. We've got the basic anatomy in mind. How do we start thinking systematically about the cause? You mentioned a framework.
Yeah, I find IMS helpful. Just helps organize your thoughts. IMS.
Okay, IMS, let's break it down. I is for?
Inflammatory, so local inflammation around the eyelids. This is a big category.
Like blepharitis.
Exactly. Blepharitis is a super common culprit, inflammation of the eyelid margins. And remember, there's anterior blepharitis.
Affecting the skin, the base of the lashes?
Right. And posterior blepharitis, which is more related to meibomian gland dysfunction, those oil glands we mentioned.
Okay.
And while maybe less common as the primary cause of really widespread madarosis, you should also keep infections of the eyelid in your differential.
Got it. Inflammatory, blepharitis, infections. What about M?
M is for mechanical, so think physical causes.
Like trauma?
Yep. Trauma to the eyelids, like burns, for instance, can just directly wipe out the hair follicles.
Oh, good.
Another one, and sometimes overlooked, is chronic rubbing or pulling. Trichotillomania.
Oh, right, where people pull out their own lashes.
Exactly.
Yeah.
Now, that might look a bit more patchy or irregular, but it's a definite mechanical cause.
Mm-hmm.
And don't forget about surgery. Any surgical procedures around the eyelids could potentially, disrupt things and affect lash growth postoperatively.
Okay, inflammatory, mechanical. What's the S?
S is for systemic. And this is where madarosis can be a really important signpost pointing to something bigger going on in the body.
Ah, okay. Like what sort of thing?
Well, certain skin conditions, dermatological issues. Think alopecia areata, that autoimmune condition causing patchy hair loss elsewhere. It could hit the eyelashes too.
Right, I've seen that.
Systemic infections, maybe even some infestations, could theoretically contribute. But a really crucial one here is medications.
Medications can cause lash loss?
Absolutely. It's a known side effect for some drugs. We have to be vigilant about that.
Any specific examples come to mind?
Well, for instance, some of the newer cancer drugs, like certain tyrosine kinase inhibitors, imatinib, vandetanib, they can cause things like swelling around the eyes, tearing, and potentially affect the lashes.
Interesting.
And even others, like some anaplastic lymphoma kinase inhibitors, crizotinib, for example, are known for visual side effects generally, so effects on the adnexa aren't out of the question. Always check the medication list.
Good point. Okay, so IMS, inflammatory, mechanical, systemic. That's a solid framework. Now, the patient's in front of you. You suspect Madarosis. What are the first practical steps? The workup.
History. History is king here. You absolutely need a thorough history first.
What specifically are we asking?
You need to know, when did it start? How quickly did it progress? Was it sudden, gradual? Are there any other symptoms? Itching, burning, redness, discharge, any feeling of dryness or irritation?
Okay.
History of previous eyelid problems,
Good point.
styes, chalazia, diagnosed blepharitis before, any trauma, even minor, to the eyelids.
Makes sense. And the systemic part.
Yes, definitely ask about overall health.
Right.
Any known medical conditions, especially skin conditions or autoimmune diseases, and, crucially, ask for a detailed medication list prescription, over-the-counter, supplements, everything.
Right. Don't forget the supplements. Okay. History done, then the examination.
Yeah, a really careful, comprehensive ocular exam. You need to look closely at the eyelids themselves and the margins.
What are we looking for in the margins?
Signs of blepharitis is there scaling, crusting, redness. Are the meibomian gland orifices plugged or inflamed?
Any
Telangiectasias. Check for signs of dacry cystitis, inflammation of the lacrimal sac. Look for any other lid abnormalities, tumors, lesions, and then assess the lash loss itself. What's the pattern?
Pattern, like diffuse versus patchy.
Exactly. Is it diffuse thinning everywhere? Is it localized to one area? Is it symmetric, looking the same on both sides? Or is it asymmetric? Note all of that down.
And obviously the rest of the eye exam too.
Of course. Full anterior and posterior segment exam. Don't get tunnel vision on the lashes.
Okay. So based on history and exam, what are some first-line management strategies?
It really depends on what you suspect is the main driver.
Right.
If blepharitis seems like the likely culprit, which it often is, then starting with lid hygiene is fundamental. Educating the patient on warm compresses, lid scrubs. That's first line.
Okay. Lid hygiene for blepharitis. What if you suspect an infection?
Then you might need antimicrobials. Depending on the suspected organism and severity, that could be topical antibiotics like erythromycin or tetracycline ointment. Or sometimes even oral antibiotics might be considered drugs like doxycycline, tetracycline, erythromycin, or azithromycin can be used for certain lid infections.
Got it. And if it seems more systemic?
Well, then your role might be more about identifying the potential link and referring. If you suspect an underlying dermatological condition or autoimmune issue, you'll need to involve dermatology or rheumatology. Maybe order some initial blood tests if appropriate, depending on the suspected condition.
And the medication review.
Always circle back to that. If a medication seems like a possible cause, you need to discuss it with the prescribing physician. Maybe there's an alternative drug or the benefit outweighs the side effect, but it needs consideration.
Okay, that covers the initial approach. Now, for the board pearl, what's a classic high-yield takeaway for exams?
All right, here's one to definitely keep in your back pocket. Think about the association. Madarosis plus signs of chronic anterior segment inflammation, especially chronic blepharitis.
So, long-standing lid margin inflammation plus lash loss.
Exactly. That combination is a really common clinical picture, and it's frequently tested. They might give you a vignette describing someone with red crusty eyelids for years who now presents with thinning lashes.
And the likely cause there is?
Most likely related to the chronic blepharitis itself, disrupting the follicles over time. But always remember the IMS differential, even in that classic scenario. Don't automatically exclude other causes, but blepharitis is the horse you should think of first when you hear those hoofbeats on an exam.
Got it. Chronic blepharitis plus madarosis, classic association. Keep IMS in mind.
Perfect.
Okay, let's quickly recap what we covered in this deep dive. We kicked off with a typical patient presentation of madarosis.
If that initial observation.
Then we touched on the essential anatomy, the follicles, the cycles, the lid structure.
Your foundation.
We broke down the causes using that handy IMS framework. Inflammatory, mechanical, systemic.
A way to think through it.
Talk through the crucial first steps. Thorough history, careful examination, and initial management strategies based on suspected cause.
Practical step.
And finished with that high-yield board pearl about chronic blepharitis.
Definitely one to remember.
Right, that wraps up our focused discussion on madarosis.
Hope that was helpful for everyone listening.
Absolutely. Stay focused, keep learning, and please subscribe for more in-depth ophthalmology explorations from Optic Surgeon.